It's not hard because you're doing it wrong. It's hard because it's hard. Some people might be doing it wrong,
Well,
but a lot of times it's hard. Go ahead, Deepu.
I was gonna say
Some
it's
people
hard
might
because
be
you're
doing
trying to
it
do it
wrong.
right.
I love that. Some people might be doing it wrong. Yes.
What
But
did you
it's
what did
hard
you say
because
again,
it's
Deepu?
he
I
said
was
it's
saying,
hard because it's right.
yeah,
To do it
right.
the right way.
To do it the right way.
Hello, welcome to the Integrated Care Podcast from the Collaborative Family Healthcare Association. I'm the production editor, Grace Pratt, and I am joined by an incredible team today. We have a full house of podcasters and guests and a rich conversation plan. So without wasting any time, I do want to get straight into some of our introductions. And we're going to start the way we always do with our icebreaker question. We in Oklahoma, we get all 4 seasons, sometimes in one day. And then about once a year, we get a huge snow and ice storm that everybody kind of buckles down and anticipates and moves. And that's coming this weekend for us. By the time our listeners get this episode, it will be in the past, but it's got me thinking about snow days and cozy days because I picked up some ingredients to make snow ice cream with my kiddos this weekend, one of my favorite winter traditions from my childhood. So as we're going around the circle, I wonder if you'd share with us, how do you like to spend a snow day? So moving around from my perspective, first we have Monica Harrison.
Hello, everyone. I'm Monica Harrison, licensed clinical social worker, clinical trainer, and implementation coach for the AIMS Center at the University of Washington. Lover of all things integrated care. We too are getting this supposed snowstorm. I'm putting it in air quotes.
Alleged.
Alleged here in North Carolina. I lived in Connecticut for many years. And the city doesn't stop for snow. Snow is just, hey, sunshine, rain, what we doing? Let's keep it going. But here everything shuts down and everyone has ravaged through the things at the grocery store. So I will be spending my time, if this alleged snowstorm comes, binge watching some things. So His and Hers is on my list that people keep talking about on Netflix. So I got a couple things on my list to binge watch. I will spend my time binge watching shows.
I love that. Staying warm, get some entertainment in, just doing some binge watching. Thank you, Monica. Next, we have Bridget Beachy.
All right. So yeah, Bridget, I'm Director of Primary Care Behavioral Health at an FQHC in the state of Washington, work as a BHC consultant with all things related to primary care behavioral health. And as far as a snow day, I want a snow day. I want this winter storm that you guys are all maybe going to get. But instead, it's just really cold and really gray. And we're in a valley. So there's like this inversion where the clouds and everything just get stuck and it's just gray, which normally in Yakima, we get a lot of sun. So I'm struggling with that a little bit. I just can't wait for the sun to come back out. But that being said, you guys know me. Ain't nothing going to stop me from going outside and doing a hike. And I love walking in the cold. I love hiking in the cold. There's just something like your legs just feel so good and you feel like you can walk forever. They get a little bit numb. I'm like, I could walk forever in the cold. So I like getting all bundled up. I always say, as long as my ears and my hands are good, then I'm good.
I love that. Hopefully, I can convince my children of that same thing. I have high hopes of us getting out in the snow this weekend. Ears and hands. I'll remember that. Next, we have Jen Thomas.
Jen Thomas, family medicine, addiction medicine, integrated care leader, Morris, Illinois, and CFHA co-medical director. How I spend a snow day. I was just talking to my husband about this because he's a high school teacher and we were comparing notes. When we were kids, we got to stay home. It was like a really exciting thing, like school's closed and you'd like go play in the snow. These days it's e-learning. So tomorrow is probably going to be e-learning for my 4 kids. One's in college, but the other 3 are probably just going to have all right, jump on your computer and still learn. So it's less exciting, I think, for them. They still have time to play and sleep in and stuff, but it's not nearly the same vibe of a free day. So what I'll probably be doing tomorrow is just making sure they're on their computers a few minutes and getting those assignments done. And then, yeah, put it all away and go play in the snow. Although I don't know if we're going to get snow. We're just going to get cold. We're Chicagoland. So like it's going to be 1 degree is the high, but I don't know if we're going to get snow, but definitely cold, but it's January. So
It is the time of year. Yeah, that
yeah.
e-learning will really crimp your style in
Right.
terms of snow day activities. Next, we have Neftali Serrano.
Yeah, I was just shaking my head at the e-learning thing. That's such a, especially with the little ones. Oh my goodness. Hi, everybody. I don't know if you can roll your R's. I'm the CEO here at the Collaborative Family Healthcare Association. Happy to be here. Happy to see all these awesome faces and talented people. Snow days, yes. So I'm in North Carolina along with Monica Harrison, and we both say alleged because the number of times that we have been jilted by these alleged huge snow events is ridiculous. There's literally been times where, like, big snow event, they cancel school preemptively. In other words, it hasn't happened, not a drop of anything has fallen, and they cancel it preemptively. And the day comes and it is sunny. There's not a drop of anything on the ground, and I'm dealing with my kids at home. So, yeah, a little bit better. So, what if it happens? Then I know a few years ago we did have a major snow event, maybe 5, 6 years ago, and it was beautiful. The trees were all covered. So what I love to do is my uncle was in the army, and he handed down to me some army gear. So like the full thing, the pants are like army snow pants and fatigues, and then this big army jacket that has Serrano on it because it's obviously the same last name. And then this hood that covers like everything, like just the whole thing. I look ridiculous, just like a short snowman, a short army snowman of some sort. And I just go out and I trudge in the snow, watch the kids watch because I'm not going to go sledding anymore. My body doesn't take that. But watch the kids in the neighborhood go sledding and be outside and enjoy that. So cross fingers it happens, but I don't know. Not holding my breath.
We'll see. I think one of us who we can guarantee is not getting any snow this weekend is Deepu George.
Hello, good morning, good afternoon, or good evening. Deepu George at the University of Texas, Rio Grande Valley. Although it is rumored that Houston is supposed to get snow, not here. So my question is, what is the snow that you guys speak of? I'm at 64 degrees outside right now. It's very nice and chill. I did live in Virginia at Virginia Tech long time ago, and we had a reasonable winter and snow. And the thing that I can think of as one, walking in the snow, which I used to love to do, or a crock pot and hot chocolate. And yeah,
I
that's
think those
about
go together too. After
I was
walk
gonna
in the
say, what's
snow, a
in the
nice
crock
warm
pot?
cup of hot
What's in the
chocolate.
crock pot?
Yeah,
The hot
what's in the
chocolate
crock
is in the
pot,
crock.
Deepu?
What's in the hot?
anything. And so back then I'm a vegan now, but back then I was not vegan. And so there was this beef stew with celery, carrots, potatoes, and beef and coconut milk. And it was lovely.
Something to warm you up. Yeah, love that. Thank you, Deepu. And then we are so excited, and I want to make a little more space for her to introduce herself a little bit longer because she's a voice you're going to be hearing more often. And we have a new regular member joining our podcast team. So, Ashley, would you mind introducing yourself?
Yes, ma'am. Thank you, Miss Grace. Hello, everybody. I'm Ashley Garrison. I am a pediatric dietitian. I work in a pediatrician's office in Burlington and Mebane Pediatrics out here in Alamance County. I have been a dietitian for over 10 years, always in the realm of pediatrics. I did do a stint for about a year in outpatient adults, didn't last very long. I'm much more of a kid person, but I am so excited to have been invited to be a member on y'all's podcast and talk about all things nutrition for babies, kids, adults, teenagers, all sorts of things, answer any questions, and really give y'all insight and some good tips and tricks that you can share with your patients, etc. I do have a master's degree from NYU. I worked at Memorial Sloan Kettering Cancer Center in pediatrics and PICU for 7 years. Then I transitioned to that outpatient role with adults and peds because I can't get enough of the kiddos, doing everything diabetes, hypertension, obesity, weight management, that sort of thing. Made my way down to North Carolina from New York and New Jersey about 4.5 years ago. Got a job at Duke University Hospital where I covered all parts of, I was the float dietitian for peds, so NICU, PICU, cardiac ICU, and everything in between. Ended my career at Duke working full-time in the NICU, which was awesome, before making my way here to Burlington and Mebane Pediatrics, where I still see a realm of everything: ex-preterm babies who aren't growing, picky eaters, texture issues, need to gain weight, lose weight, chronic disease, all sorts of things. Super excited to be here. I am also hoping for the snow, as my fellow North Carolinians are, but being from Jersey, Miss Monica from up north, I hear you. It's a joke that everything shuts down. So I, instead of going to be tramping in the snow, will be with a cup of hot chocolate, watching Disney videos with my kids, staying warm. The only thing we're picking up from the grocery store is those itty bitty little marshmallows that fit nicely in the hot cocoa cups. Again, excited to be here, happy to be a member, and can't wait to get started.
I love that. I'm so excited for you to join our team, Ashley. Yes, because of the nutrition piece, and yes, because of those aspects, but also for your role in integrated care. And when we talk about team-based care and we talk about really bringing together the diversity of voices on our collaborative teams to support patients, we are talking about a whole realm of different providers. And I think we don't hear as much from dietitians, and it's such a crucial part. And like many of our different disciplines, there's overlap in what we know and overlap in what we care about and what we see. But anytime there's a voice that's not at the table, we're missing such a rich perspective of the implications that without having that training, we aren't aware of. And so we're so excited to have you, and I appreciate you being here.
Thank you so much.
Yeah.
Yeah. And how did you get so Southern so fast? I've been here like 10 years and I'm not calling Monica Miss Monica.
Listen, I was getting ready to say, and she hit me with the miss, which is such a Southern thing. My roots are in Louisiana, in New Orleans, Louisiana, so I'm used to the Southern thing. But you hit us with the miss so quick.
Sorry. It's a respect thing. So I'm first generation born here. My parents are actually from Poland. So I was always a little bit too nice for New York and New Jersey. I fit much more the vibe down here. And so I'm really leaning into it, and it's working so far.
You got it. Yeah.
Love it. Love it. We also have one more introduction to make. We have a guest on our podcast today, and I'm going to have you introduce yourself, Michelle, and then that is going to launch into some of our conversation in a little while. So teaser for that. But we have Michelle Shrek.
Thank you, guys. Such an honor to be here. I look up and appreciate all of you, and I'm super excited to hear that Ashley's here now and permanent, because what a value add. I also work in pediatrics, so I'm a behavioral health consultant with Children's Wisconsin and one of our 22 clinics. So I talk about picky eating every day. So I'm excited to hear your take on things. We have a dietitian on our team, but she's not in our clinic. But to have one in our clinic would be like a dream come true. Super excited to hear what you have to say. I don't think you said, wait, did you say your favorite winter activity? You said staying in and watching movies? Yeah.
Yes, Disney, binge watching all things Disney, and hot cocoa with the itty bitty little marshmallows.
Okay. My favorite winter activity is becoming hockey. So my 5.5-year-old daughter and my husband play hockey. So Scott built an ice rink right outside our house. I'm getting out there and doing it. And thankfully I know how to at least ice skate. I don't know how to play hockey, but we're supposed to get wind chills of -40 tomorrow. So schools are closed. Yeah. Yep. We'll see how that goes. I don't think I'll be out there ice skating tomorrow, but over the weekend I will. Yeah.
Ooh, those are numbers that I do not recognize. I recently saw a bunch of videos of little baby kiddos playing hockey, and it was like one of my new favorite things. It is absolutely
so
adorable.
cute. They just skate and then fall, and then the dads go and pick them up, and then they skate a little more and fall. And so this is her second season, so she's making huge progress.
Oh, Awesome. Thank you for sharing that, Michelle. And I said at the beginning, I'm Grace Pratt. I am the behavioral medicine faculty at Integra's Great Plains Family Medicine Residency Program in Oklahoma City, Oklahoma. I'm a licensed marriage and family therapist, practice a medical family therapy, integrated care kind of model. And I am looking forward to, like I said, making snow ice cream. That was a favorite tradition for us and something that my kids haven't experienced very often. So I think it should be good. I'm going to have you, Michelle, in a moment, tell us a little bit more about your practice and your background and to help us as we're starting to frame our conversation. But first, Naftali, are there news and notes that we want to address?
Yeah, first I want to thank everyone who submitted proposals for our spring conference, May 6th to the 7th. Yes, our staff picked those dates because of the 6-7, very appropriate for our pediatrics oriented conversation today, for all the Gen Alphas listening to our podcast out there. So yes, May 6th to 7th is the conference. We're in the process of selecting
you
the
were supposed to
sessions.
do this.
Yeah, right.
7.
Yeah, just so I can look even older and uncooler. So yeah, so thank you for that. And then by the time you're listening to this, probably it's going to be close to the fall submission time of the year. So we're going to be in the Midwest, not too far from you, Michelle, in St. Louis. First of all, make plans to come October, St. Louis. I believe it's the first or second weekend in October. And then look out for that call for proposals. As you can tell, I think in our podcast here, we are an organization that explicitly states that all voices on the care team are important, right? And I'm so proud of just today, just seeing all these faces around here and seeing like all the different representation of disciplines and licenses and perspectives that we have around the table. We want that for the conference. That's what makes this conference unique, right? You can go to any other conference and see people who are exactly like you, right? I can go to a conference and just see psychologists. I think that's pretty boring, but you could do that. Our conference is different. Add your voice by submitting a proposal. You can check out those links at the integratedcareconference.com. Yeah, that's our news for today.
Thank you, Naftali. Listeners to our podcast know that we try to have a really good blend of real high-level topics, thinking about policy and advocacy, also really on the grounds clinical topics, thinking about how are we actually working with suicide or relationship issues or sleep or all of the many things that we've covered. And some of those topics I think are really perennial. So if you're a newer listener to our podcast, definitely encourage you go back into our archives and look for some of those topics that feel relevant to your practice. But then we also really like to try to hit some of the organizational operational challenges that come up when we think about the real implementation of integrated care, because there is no point to what we're doing if we're not able to deliver it and pay for it and really affect the change for patients at that level. And sometimes our story is cut across all of them because we know good systems theory principle, all things are connected. And what we're doing with each patient in the room is related to the organizational operational changes, is related to federal and local and state policy. And I think that this is going to be a conversation that cuts across a lot of those things. So, Michelle, could you start by giving us a little bit more information about kind of your background, but also your organization and where you guys are in the implementation of integrated care practice?
Sure. So let's see, where should I start? Prior to being a BHC, I worked in PHP, IOP, some inpatient stuff for several years at one of our local, like big mental health hospitals here, and then became a BHC in 2022. Yeah, 2022. And that's our program just started in like 2020. We are about 5 years old, and a very generous amount of money was gifted, and that's how the program started. We have 22 pediatric clinics, and we have a BHC, at least one BHC in every clinic. My clinic is one of the largest ones. Our panel size is about 10,000, and there's 2 of us there. We should obviously have more, but we're working on that. So we actually fall under, speaking to the operational part, we actually fall under, let me step back for a second. When we started, Jeff and Patty came out and worked with us for about 2 years. So Jeff and Patty both trained me when I started. And then after that, we had Bridget and David with us for about a year. So we also have learned a lot from them. So fast forward to now, gosh, I just lost my train of thought. Saying,
So you're talking about kind of the early parts of integrated care and having some
yes.
initial training out. And clearly there's been growth and expansion into your different clinics. Where would you say things are at as far as implementation now?
Now we are still learning, still growing. We're still trying to get like fully staffed with BHCs to meet the needs of the clinics. But then each clinic has its own need because some clinics are smaller. So the operational piece I was going to say, we actually fall under the mental and behavioral health part of the hospital, not under the clinical, like the pediatric clinic. So that can be a huge barrier sometimes because all the policies are different and the rules are different. Where are we? It's just, we're still working on so much. There's still so many things to sort out, and billing, insurance. We're still so young in our efforts. Yes,
So
it is.
I wonder, Michelle, if you find yourself feeling like you're working against the structure that you're within because you're on that mental behavioral health side, and yet your explicit purpose is integration.
Yes, 100%. And each clinic is so different. My clinic, my providers, there's 10 of them. They're all very open. They're all very trusting, willing. The other BHC and I come in and we say, okay, let's try this or let's do that. Yes, a very common story for sure, which is why I relate to you guys so much. But other clinics aren't as open to trying new things. So that is a barrier. And there's not like just an overall, like, this is how we're going to do it, because each clinic functions so differently. So that's definitely one of the barriers. Yeah.
listeners, sorry,
Go
I was
ahead.
just going to say, because we're an auditory medium, unless you're watching us on YouTube, which you can watch us on YouTube, you can't see the amount of nodding that's happening across our team here. Every single head
We
is
should
kind
just
of
be
on a,
going, yep, sounds
yes,
familiar. Yep,
yep,
that's about
yep.
right.
And so we have so many people on our team who've done coaching and implementation and thinking about systems. And I wonder what you're hearing, that I imagine a lot of this is resonating with a lot of our listeners as well. But what are the themes that we're already starting to see that are just so normal?
I
I
can
think,
start. Oh, go ahead, Matt.
go ahead, Monica, you go.
No,
Or I
I
should
was
say,
just
Miss
gonna.
Monica, you go, Miss Monica.
I'm gonna die over here. Although I appreciate this is the year of 50, so I'll take the.
Hey.
One of the things that there are many things that Michelle has said that resonates with me from my time dipping my toe into and then falling. I always say I fell into integrated care. I didn't plan it, didn't know anything about it, and then it was like, oh, I'm here and figure it out. And figuring it out, behavioral health integration within a large healthcare system that it was a FQHC that at the time had not really been doing it, and just trying to figure out how do we become a part of the system and not this extra thing on the side that people could just refer to when they want to, but like this almost like a little bit of an outlier, trying to figure out how to really be a part of healthcare transformation. See us as we are your colleagues too, medical providers. We want to come to the provider meetings as well. We are providers, right? Like just having to reshape some of the thought processes within the organization about how the structure worked, who we are, what our role was. We have to see a certain number of patients, just like you have to see a certain number of patients, right? We generate revenue just like you generate revenue, right? Even though it's not all about that, but in the healthcare system, that's usually what they look at first. But so just having to really, I remember because at the time we were doing predominantly, we were co-located. We weren't even really doing full PCBH at the time. We were really just co-located. And so as we were trying to transition to more PCBH and what that looks like, and then eventually we added on collaborative care, having to really start with, we need them to understand where we fit in the structure of this, how we work alongside them and not like the afterthoughts, just doing a lot of that kind of work. Providers who left us, like they no problems. but still, it was that just changing of the structure and dynamic that I found to be one of the really first things I had to do that was more challenging than I anticipated. So I resonate with that part, a lot of parts, but that part in particular was ringing very loudly for me in my head, not.
Yeah, a lot of it also goes back to simple org structure, right? Our problems in the fragmentation of medicine just go back to the ways in which we've all aligned ourselves by tradition. And when you do have a large system and you have a silo that is the mental health silo and then the physical health silo, and then an organization makes a decision to say, this integrated care thing, we're going to put it in the mental health silo because that's where we think it belongs. Then we're having to almost dig ourselves out of the mental health silo to build bridges over to the physical health silo. But the very practical problem that I've seen time and time again is that it's hard to solve problems that way. So when I say solve problems, in any organization, you have problems to solve on a day in, day out basis. You might have a protocol that you need to implement. You may have flow issues that you're trying to solve. You may have just simple sort of employee issues and what budget does this employee fall under, that kind of a thing. So there's all sorts of organizational problems that are normal that you need to solve. But if you're in one silo and what you're doing really has to do with the other silo, how do you solve that problem? How do you have any influence, for example, on the medical provider group? They're in the other silo, right? How do you work with the clinic manager? They're in the other silo. That organizational structural issue is one of the things I typically try to tackle. And the first thing I try to tackle with an organization when I'm doing some consulting work with them is it's like a mindfulness intervention. It's, hey, this is what's happening. This is why you're struggling with this because you're stuck in a silo and you're not giving your people the ability to solve problems. So how can we structurally make changes so that your, say, behavioral health director can solve problems effectively across the silos? And sometimes that means reworking the org chart a little bit, right? So that the behavioral health director actually doesn't sit directly under the leadership of the one silo, but might have maybe a joint supervision between the two silos. Or even we just decide, hey, let's shift them over to the medical silo because that makes more sense. Or we figure some other hybrid solution between those two things. But you've got to look at the org structure. It really, you can't solve problems in an organization without a good org structure.
Imagine that in 22 different clinics. So like you said, the clinic managers, and it's even more challenging then.
Yeah, something you just said, Naftali, made me think too about what Bridget dropped in the chat and ever talk more about or ask her to talk more about that, if you don't mind, Bridget. Is a lot of what we have to think about is the link between this, okay, the org chart, the policies, the who's supervising who is way up here. But what about on the ground in the room with patients implementation? And you had mentioned you have two people for this huge panel. And one of the things that Bridget had commented on in the chat that I'll ask you to speak for is how important those ratios are. And I think that's one of those big links between the organization and like the direct implementation of the clinical practice. Could you say more about that, Bridget?
Yeah, and obviously, I think Michelle already knows my view on it. But for the listeners out there, in terms of, and sometimes things aren't up to us. That's another difficulty that when places get integrated care, right, they get so excited about it in some ways. And as people mentioned, there's people who are for it. There's people that are like, eh. But the people for it, they want it everywhere. And it's okay, we got these BHCs. We're going to get them to all of the clinics. And we're just going to go and we're going to do it now. We're going to train them, maybe, if you're lucky. We're going to do a little bit of training, and then we're going to send them out to their clinic, even though, as we mentioned, we have no real org structure to it. So people don't know who their boss is. They don't know what the policies are. So the unpopular view that feel like I've expressed this and it has not gone well, which at this point in my life, I don't care, is you got to get it right at a few clinics. And you get it right by having the right amount of ratio, a 1-to-3, where there's one BHC to 3 PCPs so that you can actually deliver on what you say you're going to do. Because if you say you're going to be there for warm handoffs and you say you could help with all these conditions, and then you get into a situation where it's a 1-to-10 ratio many days, or 2-to-10, or I guess 2 to 10 would be 1 to 5, 1 to 5, 1 to 6, 1 to 7, you can't execute on what you're doing. So then the people that need to be championing you, which are the physicians, if they don't feel an impact, they're kind of like, meh, all right, flavor them, flavor of the month, flavor of the year, flavor of the every 5 years, somebody comes in and tries to change everything up. So you need to have where they actually feel it, where they're like, oh my gosh, this makes a difference. We have, I don't want to put anybody under the bus here. Okay. We've had some providers who've worked at a place that had integrated care, and air quotes for people who can't see me, who've had integrated care. And then they're told here that we have integrated care. And then the first 3, 6 months, they don't refer anybody to us. The medical boss, basically, direct medical director, asked them why not. And they say, at my last place, I just would refer them because I couldn't really ever get them in the room. So it normally takes them like 3, 6, 9 months to just even recognize in our system that when we say we're available. And the only way you can have that is with having good ratios. Long story short, I like to get proof of concept where it's actually working really well at a few places, and you get it down and you get buzz around it, and people are saying, hey, this is really helpful. They're liking it before then moving on to a next clinic. But there's always that tension where it's, but how you're really saying that we have these clinics and we're going to just keep it from 10 of the clinics and we're going to do it in these 10. And so I have so much empathy for that. And it's not always up to the BHC person to make that call. So I have empathy for it. And at the same time, it's so key because you're really setting the team up for failure in some ways. If you're saying we could do all these things and then you get there and it's 1 to 7 ratio, 1 to 10 ratio, and you can't do it.
I think it's important, something you just said too, Bridget, is we don't want to be dismissed as, oh, this is just every few years someone comes in and tries to try this or tries to change it, because the stakes in some ways are really high. If implementation goes poorly and then is abandoned as a failed effort, in my opinion, it takes, or what I've seen is it's going to take years before there's enough like washout and changeover in leadership, or like that bad taste is out of people's mouth and they're willing to try integration again. And it's hard to watch, I think, sometimes when we see it being implemented like halfway or with like I don't know, not a real effort, or verbally they're saying, yeah, we believe in this, but that's different than putting resources behind it when you can anticipate that it's going to fail. And then it's not just that program failing, it's also the opportunity cost of what could have been in those next however many years it's going to be until someone is willing to try again.
I will say, for those of you who are listening, who are probably experiencing a lot of this, what we're talking about, what Michelle's talking about, I think I wholeheartedly agree with Bridget and think that although you may not be the one that makes the final decision, and often we are not, you do have the opportunity to share the knowledge and information that you do have. So there is research out there. There's implementation science research that's out there. In addition to the ratios, you also want to think about the capacity of that person, because if you have 1 to 3, 1 BHC or 1 RD, because I've been in a clinic where me and the RD had to tag team leadership before as well. But if it's 1 to 3, but you have me seeing patients, I'm doing PCBH, but then you also want me to do collaborative care, or you also want me to do referrals for these other parts of the clinic, and you also want me to do, right now you're adding other responsibilities. Now it's even more than just about the ratio. It's also about that capacity that you're giving me to do that job and be available to the providers for the warm handoffs. And so those are things that, although we know it, sometimes what leadership needs is the documentation to back it up, the research, what other people have said. And you may not make the final decision, but you do have an opportunity to pull some of that research, hit up your CFHA listserv and be like, hey, I got this going on and that going on. People will flood you, believe it or not, with research, and I have this and I have that, and try this, because you can at least educate them. And just like with patients, where sometimes it takes multiple times that we have to tell a patient something and then a piece clicks, sometimes it's like that with leadership as well. Sometimes they have to hear it multiple times. Sometimes they do it their way, it fails, and then they're coming back to have another conversation with you. So don't be defeated if it doesn't go the way you wanted it to go out the gate. But have your research, your documentation, your suggestions, have that stuff on the ready.
Yeah. It makes me think of like implementation journey for us. Like we were recipients of Monica's fantastic AIM Center implementation coaching. And our team jokes that we thought this was going to be like a slam dunk, like they were going to give us this great like sports car. We are just going to zoom off to the sunset and everything was going to be great. And it was like totally not that experience. The training was good, but then we quickly realized it's us. We have to, they're not giving us a car. We're building our own car and we don't know how to build cars. Ours is like a clunky, we're like, it's a lawnmower. It works, it moves, but it is not cool and it is slow. And we are not arriving at that destination anytime soon. And that's okay. So I guess the question I was thinking was, is some integration better than none? Depends on the day. Yes, I guess pessimistically, I'm like today, but yes, I think you got to start somewhere because if you don't start, you'll never start. You got to get in the weeds in the mud and ask your CFHA friends, where do I go from here? Because this stuff's tough. It is not linear by any means.
That's a very pertinent question for us in our technical assistance program here at CFHA. And we had a really bad situation this last year. I'm not going to obviously name names, but we were contracted to work with a clinic. And I really, in retrospect, was kicking myself because in retrospect, I wish I had the guts to tell this clinic from the get-go, you're not ready. And because there is a threshold at which some integration is not better. And it's counterproductive. And that was the case with this clinic. And it took us 6 months to get to that place of trying this and trying that. But it was just a place that frankly was not ready organizationally. And that's the key thing here. We always have to remember this is about organizational, team-based transformation, right? So if an organization's not really ready to embrace that, there is, I think, a threshold, and there's nuance there. It's what that threshold is, right? And lots of factors. So it's not some perfect equation I can give you. But there is a threshold at which if an organization's just not willing to make the structural changes, not willing to invest provider time and energy, not open to making the changes to support their staff in particular, then no, some integration's not helpful. Stay co-located. Do what you're doing now because transitioning is going to be more of a show than anything else. And it's going to set you back down the road for when you might be ready to embrace that. So yes, there is a threshold. I'm still learning what that threshold is, obviously, in terms of how to make that happen. But this is integrated, team-based care is a thing. It is different. It is quality. In fact, this reminds me, on the listserv, Dan Mullen and colleagues, he wasn't the only author, but he's the author I remember on the paper, this really important paper that came out last September that showed that there is a correlation between the level of integration as measured by the practice improvement profile, the PIP, I forget the name of it, but the PIP, a standardized way of evaluating your level of integration, there's a correlation between that and the quality of care that is provided across both mental health and behavioral health outcomes. It's a really important finding that a lot of us who've been doing this work knew intuitively, right? But what that tells you is, yeah, the more integrated you can get, the bigger difference there's going to be in the quality of your outcomes. And to your question, Jen, I think if you can't pass a certain threshold, what you're doing actually becomes a little bit counterproductive.
I am listening to our conversation. I always love to listen as we're talking and I feel so lucky to get to hear from so many smart people. And I don't want our message to be like, it's too hard, don't try.
No.
And I know that the people and the years of experience represented on this call are trying to be realistic. And I hope that instead of it's too hard, don't try, what listeners might hear is that if it feels hard, then one of my favorite things to say about parenting, about residency, training to my trainees, about integrated care is it's not hard because you're doing it wrong. It's hard because it's hard. Some people might be doing it wrong, but a lot of times it's hard. Go ahead, Deepu.
I was going to say
Some
it's
people
hard
might
because
be
you're
doing
trying
it
to do it
wrong.
right.
I love that. Some people might be doing it wrong. Yes.
What
But
did you
it's
what did
hard
you say
because
again,
it's,
Deepu?
he
I
said
was
it's
saying,
hard because it's right.
yeah,
To do it
right.
the right way.
To do it the right way, it's going to take some effort and energy. And I think hopefully what the listeners are taking in from Michelle's reflections is that this is a typical journey and you're not alone. And it's just focusing on what is controllable, shaping providers' behaviors, building relationships with patients, MAs, front desk. And that's what's going to get the message moving through the system in a lot of ways, especially when you don't have a seat at the table or you're not in the decision-making boots, right? And like thinking grassroots organization, right? Like how do we build energy and relationships that are almost they can't live without kind of a feel. And then I think that can do a lot of work. That doesn't take away from all the other organizational stuff that we talked about. But for Michelle and folks in Michelle's seat, that's what I think about as at least that was our journey when we started.
To just give some hope, I focus on what I can control, just like you said, Deepu. So I focus on my not little clinic, thank you, Bridget, and my 10 providers and building that relationship with them and educating them and teaching them and getting that trust. And that is where that like fulfillment comes in and that progress. And that's why we do it.
Yes,
Yeah.
coming back to meaning and purpose. It's so protective. This is such a good conversation, and I'm not ending it, but I do want to shift us a little bit just to not miss our opportunity for something unique about your practice, Michelle, of it being so focused on a pediatric population. I think a lot of integrated care that we see, it has been traditionally in like broader primary care and family medicine. And I love hearing efforts about integration for different populations and different settings. And so I wonder if you could speak a little bit about what some of the unique assets or the unique challenges about working in that primarily pediatric environment.
That's a great question. Let me think on that for a second.
And I would ask Ashley to chime in too, because Ashley, I
Yeah.
know that you have done your work with kiddos.
Yes.
You said,
Sorry, go ahead.
I was just going to say the opportunities. Kids are so funny. Like kids don't have a filter. They say the funniest things in front of their parents, and then the parents get embarrassed. But I would say there's another layer of we're working with adults too, right? Because most of what we do is working with the parents. So you have to have that skill to go back and forth between talking to the kid directly in the visit, not ignoring the kid, but then also talking with the parent, engaging the parent, teaching the parent. Tons of psycho ed. That's one of the biggest things we do. We do a lot of assessments for ADHD, anxiety. We use the Promise, 4 different assessments within the Promise in our clinic. So we're doing like research around that and just building those relationships from like literally birth. I get to go in and meet like a newborn and first time parents and like, how are you guys? And then 6 months later, they come back in and now baby's bigger and what's new and they're sleeping and rested and just that whole like up until they go to college. And I've only been there just about 4 years, but I've already sent kids off to college and I'm like, I'm going to miss you guys and come back and see us. So it's such a privilege to be there with those families at those really fun times, but then also like really hard times. Like parents just suddenly pass away. So we see kids for that. It's just such a big variety. Go ahead,
And if I
Ashley.
could piggyback on that, because I think you said it so eloquently and so beautifully, but I think the fact that we're setting kids up from birth, right, with all of these tools, helping the parents with things that maybe they didn't know, didn't have access to. And so, yes, we focus on the child or the patient, but we are healing the whole family and setting up the future. Like these kids are going to go into it with such a different base of knowledge and support and education that the generations before them didn't have. And as much as, to your point, I love the itty bitties and I've sent a couple of kids off to college too. And same thing, I'm like, I'm going to miss you guys. Don't forget about me. But I think it's this that's one of the, I think can always be very challenging and very tough because to Michelle's point, we've got to engage the kid. I've got to get buy-in from them. I have to get them to trust me and want to keep coming back to see me, or wanting to believe and make the changes that I'm recommending for them, whatever that may be. But the child isn't the one going to the grocery store. The child isn't the one cooking. The child isn't the one that's making these decisions. So it's also truly getting that buy-in from the parents and getting the trust from them too, so that truly the whole house can change with whatever recommendations we're making, whether it be behaviorally or nutritionally or whatever the case may be. And I think that's one of the greatest honors and responsibilities, but also one of the biggest challenges, is that it's not just the kid, it's the whole family. And that can be tough.
I'm
It's
wondering too,
important.
Ashley, as you hear our conversation about the organizational pieces, I'm wondering if you can resonate with some of the challenges. You're not a behavioral health professional, but actually I would argue you are, because you're helping a lot of behavior change. But so feeling siloed, feeling like the ratios are off. I'm guessing this is part and parcel of your world also.
100%. And for those who are just listening, I was nodding my head the whole time and waiting to get my chance to get in there, but I couldn't agree more. My practice, we serve 18,000 patients in Alamance County. We are the largest pediatrician's office in Alamance County. And Dr. Boylston actually used the COCM model. We have 2 LCSWs. They are amazing, wonderful, incredible people, but she used that model to bring me on board. And I will share that there was some providers who were like, we don't need a dietitian. We've been giving dietary advice for 30 years. What is she going to say that we don't? And to that point, I had to come in and be like, yes, you're doing awesome. Here's what I can give to you. And I was going to share that education to the providers of, y'all are doing amazing. Here's what I can bring, because this is the only thing I have a degree in and focus in and expertise in. And really building that relationship of, I'm here if you need me, but here's all the new data. Here's all the new research. Here's all the new tools where, for example, doctors for 50 years have been telling kids eat more vegetables. It's not really working, y'all. It's not making the changes that we were hoping for. And so me coming in with a different perspective, but definitely to that point, having to earn the trust, the respect, and now becoming something that I lovingly, that my providers tell me, is that they can't live without me. That's the point. And if more people could get on board with that, and more people could, but it is taking a step out of a comfort zone and going out there and being like, I'm great at what I do. I'm really smart. I have loads of ideas and I can help your patients. That's great. But then getting behind it and really convincing the non-believers of, hey, you've done this alone for 30 years and that's great, but now you have me. Let me take that off of your plate and let me really help, so that you can focus on the part you're really great at, which is the medicine. And then we have someone else who can focus on the behavior, and I can help with the nutrition. But that all coming together, y'all, has done wonders for our patients and their families. The progress we have made and seen is astronomical. And so I'm excited that I never knew about COCM because I was always in an inpatient setting, and coming to this practice, I was like, whoa, why does not everybody have this? Like, it's amazing. And I feel like the little sprinkles on top, I'm just a little extra something, a little extra pizzazz to help really close the loop.
I love this conversation. I love the parallels. Everyone in the chat saying, yes, it's the same, because it really is. And Monica just had to run, but she said some of her favorite work in integrated care has been working with the dietitian, working with the pharmacy. We need more people on our team. We need your voice. We need that perspective. It's the same arguments and all of those pieces. And we're excited to have you here and to have you along. I hope that there was something from this conversation for everyone in terms of whether it's seeing a bit of yourself in the challenges that Michelle has faced, whether it was connecting to the hope of the meaning of the work that we do, because that's what came through for me. I love seeing both of you light up when you started talking about peds and what's special about working with kids and the hope that comes with that. And you're very much speaking my language, talking about families and systems. And we're the Collaborative Family Healthcare Association for a reason, because thinking about the family as the unit for change is such a key piece of what we do. And the buy-in of that comes so readily when it's parent bringing a kiddo. Clearly, everyone needs to get on board. So thank you both so much for sharing those things. I am looking forward to continuing to expand this conversation. We didn't get much actually this time in terms of like high level policy and what's happening like at a federal level and how that impacts the work we do. But that's what we want to continue to talk about too, because again, when we think about the hope that comes with working with peds and with kiddos, policy is also such a really impactful thing that is so clear there. And recent changes have made that really clear from our federal levels in terms of recommended vaccination schedules and how we're talking about dietary nutrition requirements. And I think that leaves a lot of questions for parents who just want the best thing for their kiddos. And there's a lot of different information coming around. I know that has an impact in our clinical work and in our organizations. And so that's a little preview for, I think, where we're going to take this conversation next time. Before we go to closing thought from Deepu, does anybody have any final thoughts that you want to share as we wrap up this conversation today about really just holding a mirror up to the process of integration and implementation and what that can look like?
I would just encourage our listeners to imagine going to a clinic where you had these people there to care for you. And just imagine that and wonder, wow, how different healthcare would be like if that were the norm.
It's a vision for sure. Michelle, thank you so much for being here. Thank you for being willing to share your story with us and with our listeners and giving us that space to reflect.
Thanks for having me, guys.
Yeah, and thank you, Ashley, for joining our team. We can't wait to continue to hear your voice and what you bring to our group.
Thank you so much. I'm so happy to be here.
Yeah, let's go to Deepu, who has a closing thought for us.
Okay, since we talked about peds and children, this is a part of a poem from the poem called The Prophet by Khalil Gibran. And there's a section called On Children where a woman asks him about children. I think this is a great thing to share with parents when they are struggling, and how do you differentiate yourself from your child and be able to be a presence. That this has helped me and it has helped my parents and it's helped many other parents too. So here it is. And the woman held the babe against her bosom and said, "Speak to us of children." And he said, "Your children are not your children. They are the sons and daughters of life's longing for itself. They come through you, but not from you. And though they are with you, yet they belong not to you. You may give them your love, but not your thoughts, for they have their own thoughts. You may house their bodies, but not their souls. For their souls dwell in the house of tomorrow, which you cannot visit, not even in your dreams. You may strive to be like them, but seek not to make them like you. For life goes not backward, nor tarries with yesterday. You are the bows from which your children as living arrows are sent forth. The archer sees the mark upon the path of the infinite, and he bends you with his might, that his arrows may go swift and far. Let your bending in the archer's hand be for gladness, for even as he loves the arrow that flies, so he loves also the bow that is stable.
Thank you, Deepu. Thank you for our team for being here and for our listeners for joining us. We'll talk to you again next month.